So it's very interesting. So we always were taught that most cases of hypertension are what's called essential. So we typically never found a reason for why blood pressure is elevated. And now, I think in the past couple of decades or so, we realized that more and more often we find that there's actually some underlying cause, and in a lot of patients, especially those with resistant or more severe hypertension, we find aldosterone dysregulation as a driver of blood pressure increases. So that's sort of a new approach because, and it's important to understand that because there's some very specific and tailored therapies for that aldosterone problem. So hypertension clearly is the #1 modifiable cardiovascular risk factor. So controlling blood pressure is absolutely crucial to improve cardiovascular outcomes, to lower mortality, and make people with hypertension live longer. So recognizing that hypertension is important, measuring blood pressure correctly, and then addressing the blood pressure and prescribing appropriate medications to bring blood pressure down to goal, which currently is in most patients 130/80, is absolutely crucial to improve overall patient outcomes. So there's a good amount of data now that shows that increased aldosterone production is actually linked with poor kidney and cardiovascular outcomes. Most of the evidence comes from observational studies where we just simply compare patients who do not have primary aldosteronism but elevated blood pressure to those patients who have elevated blood pressure without primary aldosteronism. And there's some distinct differences between the two groups. For instance, the rates of heart failure, the rate of ischemic heart disease, the rate of atrial fibrillation, stroke, all is increased when aldosterone is the driving force of elevated blood pressures. And on the same time, kidney outcomes such as progression of chronic kidney disease or even the incidence of end-stage renal disease and dialysis is also increased in those patients with primary aldosteronism. So there's a lot of new medication classes currently under investigation. I think the bottom line is we need new approaches. We need some new approaches that, first of all, address this aldosterone dysregulation and increased aldosterone levels in the treatment of hypertension, because those therapy options will most likely also reduce other cardiovascular problems. And in general, when it comes to treatment options, anything that can improve adherence because the side effect profile is more benign, or other treatment options that just support good blood pressure and bringing blood pressure down to goal will help patients with hypertension with or without aldosterone problems.